Hello, hi, Dr. Mngoma.
Hi. Sorry, I joined a bit late, but yeah. I hope the general plan is I'm coming at the end, is it?
Can you hear me? Hello?
Now I can hear you.
Great.
Yeah, I can hear you.
Okay, all right. So I think just as we had the discussion yesterday, you'll be coming in after the presentations done by Jane to just do the presentation on some of the work that has been going on, especially on the trainings, and then thereafter we'll have the Q&A session. Good evening, Dr. Isaac. Welcome.
Masabidi ndio was. Masabidi ndio was.
Sorry, Dr. I'm not. Hi, Dr. I'm not sure if we can hear you clearly. Hi, Doc.
Malonza, Dr. Malonza, your mic is not muted. Welcome though for the webinar. Dr. Mngoma, welcome.
Friend yake kazi UN represented.
Hello, good evening, everybody. Can you hear me?
Yes, we can hear you, Jen.
Oh, thanks. I just wanted to check that.
Okay.
Good evening, everybody. Can you hear me?
Yes, we can hear you.
Good evening, Dr. Mtisia, Raymond. Welcome to this webinar.
Yes, good evening, Dr. Joy Kamau. Asante.
All right. Good evening, esteemed members, and thank you for joining us today. If you can hear me, just send a message on the chat and let us know which PSK branch you're joining us from. All right, I see some feedback. Thank you for those who are joining us. Dr. Joaquin from Kisii, see members from Narok, Dr. Edwin, Dr. Brenda from Nairobi, Karibuni Sana, Dr. Michael from Western, welcome. Dr. Elsie from Meru, Dr. Abbas from Mandera, Karibuni Sana. Thank you for joining us today. So we are not going to take much time. We're just going to start immediately because I see we already have a good number of you who've joined us. And first, I'd like to welcome you to this session 2. Remember, initially we had session 1 of dissemination of the family planning guidelines, which was facilitated by Dr. Isaac Malonza, CEO of URADCA. And today we'll be having the session 2, which is a continuation, and it will be handled by Jen Otai, who's the OPC program manager. And just before we get started, I'd like to remind you all, if you can kindly go to the PPB portal and subscribe to the event. Use the keyword family planning guideline, and you should be able to find the event. And ensure that you check that it's labeled session 2. And as you subscribe to the event, ensure that you subscribe to the event that has been organized by the Pharmaceutical Society of Kenya. If you look at the table provided there, there's event, the date, the provider, and the action where you need to subscribe. So kindly ensure that you check on that. So just a few ground rules. You're going to be muted during the entire course of this webinar. So if you have any questions, kindly use the Q&A tab and they'll be responded to at the end of the session. And also this session is being recorded and it will be made available on the YouTube page. For those who will not be able to, especially for your colleagues who will not be able to join us through the Zoom platform, the YouTube live is on and they'll be able to attend. And at the end of the session, they can subscribe. They can scan the QR code that will be presented so that they can get their CPD points. So at this point, I'd like to welcome Dr. Joe Kamau, who's the technical lead for PSK OPC project, who's going to give some opening remarks and welcome the speaker of the day. Dr. Joe, karibu.
Asante sana, Dr. Ezron. I am pleased to be here today amidst 1,000 plus members to preach the gospel of OPC, the OPC project, together with my panelists. But just before I go too far, I wouldn't like to spoil the moment because there is a speaker of today. Mine is to stress that there is a need to subscribe for the CPD points. Again, members, your screen shows how to do it and how to put in the keywords so that you get the points. So mine will be, just as Dr. said, inviting the key speaker. The OPC project has been with us. Remember, we had the first session that were taken through by Dr. Isaac Malonza. Today, we have another speaker who is also a partner in OPC. Remember, OPC has partners like In Supply, URADCA, PSK, KPA, and she's here to talk about the FP policy and its dissemination. Dr. Jane Otai is the OPC manager in URADCA. So without much ado, Dr. Jane will start. Then we shall also listen to Dr. Mungoma in the end. We'll also have another presentation. Jane Otai, take it away. Thank you very much.
Thank you so much. Before I start, and good evening, everybody who has come in. I can see we are quite a number, 1,000 participants who have turned up for this webinar. But before we start, I think Hezron will have a pre-test, which we may need to run now before I start giving the presentation. So it would be great for us to go through the pre-test, which we've been able to put together, and Dr. Hezron can share that with us. Yeah, we have it right there. Policy dissemination, pre-test. How would you like them to complete this, Hezron? Do they have it? You can give some instruction there.
Yes, thank you, Jen. So, members, if you can just look at your screen right now, there is a poll that has just popped up. So if you can kindly take 2 minutes of your time to just fill up those questions. And then at the end of the session, we'll be having another just to get your understanding of the presentation today. So kindly take 2 minutes of your time to just give us your feedback. So I see the responses coming in. Just keep going.
I think you can move on to the fourth question, third to fourth.
For those who just joined us, kindly just fill up the poll. If you look at your screen, there's a poll that has come up. I'm seeing a good number of filling in. Dr. Victor, Dr. Joseph, and Dr. Elizabeth, there is a poll that is just at the bottom of your screen. Click on the poll and the questions are going to pop up so that you can give your responses. So I see we are at almost 300 responses now. The room is at 1,000. So for those who are listening in, kindly just give us your feedback before the presenter can start. Just 10 more seconds, then we close the poll. All right, thank you. So I think I'll just share the results for our presenter to just have a look at them. So I'll start with the first question on one of the OPC primary outcomes is to optimize the pharmacy channel to provide quality FP services and promote self-care. We have 97% of you saying it's true. The second question, we have 92% of you saying it's true. Third question, which of the following is not a key reason for ensuring policy understanding and implementation? 87% of you say restriction of access to information. How does family planning benefit children? 90% of you said reduces child illnesses and death. The fifth question, family planning improves women's status and promotes equality between men and women, and 84% of you have said it's true. How does training and support contribute to policy effectiveness? By ensuring stakeholders have the necessary skills and knowledge to implement the policy correctly. That has been answered by 95% of you. So I think after this session, we'll see how the responses are going to be. But yeah, so I think at this point, I'll leave it to the speaker to do the presentation, and then we'll have just a quick test in the end to get your understanding. So maybe, Jane, you can come in.
Thank you. So let's first have the first slide. My name is Jane Otai, and I work for URADCA as the program manager for the OPC program. And today, the policy dissemination will be talking about the package for training pharmacists and pharmaceutical technologists in provision of quality integrated family planning. So you're most welcome for this session, and I believe we shall learn together and be able to understand what the policy and the guideline talks about the package for training pharmacists. Let's go on. To start with, I'll talk about the program, which is Optimizing Pharmacy Channel. We call it the OPC project. And the goal of OPC is to increase access to an expanded and quality family planning method choice, including implants for women and girls through a strengthened pharmacy channel in Kenya by 2027. This project is in its second year, and we hope that in the next 3 years, we shall be able to have an increased uptake of family planning, including implants, but through the pharmacy channel. And it has 4 primary outcomes. The first outcome is to have an optimized pharmacy channel to provide quality family planning services and an expanded method choice and promote self-care. The second outcome is we hope to generate evidence on feasibility and acceptability of implant provision by pharmacies in Kenya. The third outcome, we shall have a strengthened policy and regulatory environment to enable an expanded and quality FP method choice provision, including implants at pharmacies in Kenya. And the fourth primary outcome is to have an increased number of women and girls accessing and continuing quality self-care and family planning products and services from pharmacies. And maybe something that I need to say is that this program, the prime for the OPC program is in supply, but the other partners are URADCA, which I work for, Pharmaceutical Society of Kenya, and the Kenya Pharmacy Association. So those are the partners who are actually implementing this program. Yeah, let's move on. I'll talk about URADCA, the organization that I work for. And in URADCA, we we imagine, innovate, and inspire. And we are a public-based organization registered in Kenya. We were registered in 1996. Our vision is that no one should die of preventable diseases and lifestyle conditions. Our mission is to improve the health and well-being of African people, and our approach is advocacy, research, policy analysis, health evaluations, and capacity building. You can see the building. We are actually housed on Kindaruma Road at Violet Plaza, and on the 6th floor. We are actually in room 6 or 7. So that is where we are actually housed. Let's go on. Why are we disseminating policy? We realize that the government has really comes up with very good policies. We have the Ministry of Health coming up with a number of policies, but not many of these policies are known by the people who should actually be referred, by the people who should refer to them and use them to be able to work and implement some of these policies. So the reason we are disseminating the policies to ensure that the policy is well understood, it's actually implemented and followed effectively. The key reasons for the dissemination is to create awareness and understanding, to create consistency, compliance, transparency, empowerment, adaptation and feedback, training and support. Our overall aim is to ensure the policy achieves its intended goal, which is the public, which has public health impact. So we are hoping that all this time that we are disseminating the policies, you'll be very aware of what the policies are, understand them, and also be able to implement them and comply with them in some instances, in all instances. Yeah. Let's move on. Today, we are the policy, the guideline. Actually, this is a guideline that we are going to disseminate. And it's the guideline is how we shall expand access and choice to family planning services in Kenya. This is a participant's manual, and it's a package for training pharmacists and pharmaceutical technologists on provision of quality integrated family planning. When you look at the contents of this participant's manual, which was actually written in 2019, it has 11 units. And in the 11 units, we have the introduction to the course. We have the overview of family planning in Kenya. It talks of basic anatomy and physiology of the human reproductive system. It also talks about counseling for family planning, medical eligibility criteria for family planning, infection prevention and control, contraceptive methods, family planning methods, how we can integrate and refer for family planning. It goes on in Unit 9 to talk about documentation, reporting, monitoring, and evaluation. Unit 10 talks about reproductive health, commodity management, and the last unit, Unit 11, is about pharmacovigilance. So these are the units that I'll be talking about. I'll be able to summarize each of these units so that you can understand. I'll not go into detail, but I'll summarize each of these units. Yeah. In addition to this package, there are other packages for training pharmacists and pharmaceutical technologists, which you should be aware of. And I would encourage each one of you to get hold of these training packages because they support the package that I am going to talk about today. And this is expanding access and choice to family planning services in Kenya. It is the trainer's manual. And we also have a logbook that you can use to be able to actually to work with this package while to use as a logbook so that when you are implementing or when you're practicing family planning, you can log in the hours you've done, what you've been able to do, and all that you need to put in the logbook so that you can qualify as somebody who has actually gone through this training and can be certified to offer family planning within the pharmacies. So these are two of the additional packages that you should be aware of. But I'll not talk about them so much. I'll only talk about the participant manual. We talked about Unit 1, which is the introduction to the course and the purpose of the manual. This manual is designed for pharmacy and pharmaceutical technologists. It has essential information required by the participant and the trainer to offer family planning services. The manual has a brief introduction, followed by the objectives of the units. It instructs on group work. It instructs on group work units, step-by-step instructions on how to perform various procedures on the humanistic models and on clients. Yeah, that's Unit 1. Then the goal, it also talks about the goal of this participant manual, and the goal is to expand access to and choice of family planning services and HIV preventive services through integration in pharmaceutical outlets. And you'll be able to have knowledge on family planning program in Kenya, knowledge on the basic anatomy and physiology of human reproductive systems, skills and competencies in counseling for family planning methods and HIV prevention, skills and competencies in medical eligibility criteria for family planning. Let's go on. It also talks about the skills and competencies in family planning, infection prevention and control practices. It will teach you about the skills and competencies in FP methods. You'll acquire knowledge on integration and referral. You'll acquire skills and competencies in documentation, reporting, monitoring, and evaluation. And by the end of this training, you will have the knowledge on reproductive health, commodity management, and pharmacovigilance. So this is a manual that is actually very good for you to be able to learn so much about family planning. In Unit 2, it talks about the overview and facts about family planning in Kenya. And in this manual, the manual has been able to summarize the Kenya Demographic Health Survey of 2014, where it says that 34% of modern contraceptive users obtain their method from the private sector, of which pharmacies provided 10%. Private pharmacies mainly provided pills at 45.4%, condoms at 16.1%, and injectables at 5.4%. The introduction of DMPA is an opportunity for private pharmacies to play a greater role in provision of injectable contraceptives. Kenya Family Planning goals is 66% by 2030 and 70% by 2050. So with these goals, pharmacies have an opportunity to contribute, and they're already contributing, but when we go through this training, more pharmacists and pharmaceutical technologists can contribute even more for Kenya to be able to achieve these goals as by 2030 and by 2070. And every county contributes to this family planning goal. We continue. When we look at the method mix, there have been changes for modern methods in Kenya. We are comparing the manual talks about Kenya Demographic Health Survey in 2009 and what has changed by 2014. When we look at a few of these, we can look at, for instance, family planning injections. In 2008-09, the FP injections, 55% of the women were on FP injections. But in 2014, this reduced to 50%. But when it reduced to 50% there, we can look at the implants. In 2008-2009, it was 5%, but it has increased to 19% in 2014. So you realize that in some of the FP methods, some have reduced and changed methods from, for instance, injectables and changed to implants, while some have changed maybe from implants, from pills, which was 18% in 2008 to 15%. It has reduced. But when it reduces in that, then they change to other family planning methods. So over time, women decide whether they want to continue with a particular method or they want to go for BTL. They're finished. They are done with having children. They change to BTL. But some of them have increased. For instance, implants. There is more desire for implants for women, looking at 5% in 2008 to 14% in 2014. So there is an opportunity for pharmacists to actually be able to offer family planning and implants in particular, if the policy would allow them. Currently, the policy does not allow the pharmacists to offer implants, but injectables they are able to offer, pills they are able to offer, condoms they are able to offer, but these other methods which are long-acting and reversible contraceptives they are not able to offer. So is this an opportunity? Is there an opportunity for pharmacists to also get into these other long-acting and reversible contraceptives or even implants, for instance, so that for the women who desire to have implants, there is no missed opportunity there, because there are many advantages for women having implants instead of the short-term methods. Let's continue. It also talks about the benefits of family planning. There are benefits for women, there are benefits for children, and there are benefits for families and communities. I'll just give one example. For instance, family planning has a benefit for women because then there is low risk of anemia or poor pregnancy outcomes and complications related to miscarriage or unsafe abortion. And for children, it allows more time and resources for parents to meet the needs of each child. And for the families and communities, there is reduced maternal mortality and there is strengthened families. It also strengthens families and communities. When we look at another benefit, which I'll talk last, there's low risk of certain cancers and other gynecological problems. That's a benefit to the woman. But with the children, it also improves mother and child bonding. It reduces child illnesses and death, and it also provides good nutrition for the baby. And for the community, it enhances women's status and promotes equality between men and women, and it improves education and economic opportunities within the communities and also for the families. So there are quite a number of benefits. I'll not go into each one of them, but when you see there is actually quite a number of benefits, even maternal death, it reduces maternal death, longer breastfeeding for the baby, and families can devote more resources to providing for each child. So those are some of the benefits of family planning that the guideline shows. However, there are trends of unmet need of family planning in Kenya. When we look at 1993, the unmet need was 35%. But over time, this has improved. By 2014, the unmet need has reduced to 18%. This implies that more women are now able to access family planning, which is a good thing. But we are still way we are very far from the goal that we have set ourselves for as a nation. So there is improvement over time, but there is still more room for improvement. When you compare 1993 to 2014, you can see that trend, and there is improvement in unmet need of family planning. Yeah. While there is improvement, there are quite differences within the various counties. Let's look at Mandera, Wajir, Garissa, Turkana, Marsabit, and West Pokot. The modern contraceptive rates within those counties in KDHS 2014 was between 1 to 14%. But when you continue, you can see that in the other counties, we have in Isiolo, within Isiolo, Tana River, 20 to 35%. When you go to Laikipia, Bungoma, 50 to 59%. But when you go to Meru and Kirinyaga, 70% of women actually take on family planning. So there is quite a difference between these counties. We are within the same country, but some counties are doing much better than other counties. And what is the reason for this? Maybe we should be that the guideline tells us exactly what's happening in these various counties, and you can look at your own county and see where you are in this graph, and maybe decide to do what should be done in your county to increase FP uptake among the women. Yeah. So let's move on. Then we have, it also gives us the teenage pregnancy rates. And for the KDHS 2022, for the girls who were 15 years, 2.1% of them were pregnant, became pregnant. When you look at 17 years, 10% of them fell pregnant. 19 years, up to 27.4% of girls, 19 years, have become pregnant as per the DHS 2022. So the pregnancy rate within our country is quite high when you look at the age, because if a girl becomes pregnant at 15 years, then her chances of completing education are minimized. When the career, they cannot be able to complete school, their careers are affected. And at a young age, even their own health is at risk. Many girls at that age would lose. Maternal mortality is high among the younger girls getting pregnant compared to women who have been able to develop and are able to carry a pregnancy to term. So family planning would also reduce teenage pregnancies among our teenagers and reduce maternal mortality even among the young girls. So this is something that we can say that family planning has an advantage even for the teenagers, so that they don't fall pregnant when they're still in school, when they haven't yet become mature enough to carry pregnancy to term, and we can reduce mortality among them. So this graph really shows the teenage pregnancy within our country. It's gone. But there are challenges in the realization of the national family planning goals. And some of the challenges is that there is a wide county and socio-economic disparities in contraceptive prevalence rates. There is a lack of contraceptive commodity security and sustained demand creation for family planning services. There is a relatively low community and private sector participation in family planning service provision and low male engagement. There is a low uptake of cost-effective methods, such as long-acting and reversible contraceptives and permanent methods. So, but there are more challenges. We can continue and see the other challenges in the realization of the National Family Planning Goals. Yeah. Can we continue, Hezron? There is also inadequate capacity for provision of quality family planning services in terms of provider skills, equipment, and supplies. There is also a low level of integration of family planning into other health services. And this creates missed opportunities for women who would have loved to take on family planning, but she came in maybe because she has malaria and the service provider only provided services for malaria and did not talk to her about family planning. So we have a lot of missed opportunities when we do not integrate family planning into other health services. There's also a difficulty in access to contraceptive services for adolescents, youth, and hard to reach populations and people living with disability. For instance, many adolescents even fear to get into the health facility because the health provider is not willing to offer them information and even family planning services. So many of them fear to get into the health facility because Watasomewa or the health provider is not willing. She has her own biases, she has her own beliefs and values, and is not ready to offer family planning to adolescents, especially those who are not married, those who are in school. Youth also have a difficulty in accessing family planning, and there are some of those populations that are hard to reach. We already saw that in populations in Garissa, Wajir, Turkana, family planning services are not, the uptake is much lower than in places which are easier to reach in Kirinyaga and Meru. So those disparities also contribute to the low uptake of family planning and the barrier for us to reach our national FP goals by 2030. Yeah. Then in Unit 3 talks about the basic anatomy and physiology of the human reproductive system. In the training manual, it covers the basic anatomy, physiology of the female and male reproductive systems. And this is important in understanding the structures and the functions of reproductive system in relation to contraceptive use. The unit provides insights on the anatomy of female and male reproductive system, physiology of female and male reproductive system, menstrual cycle, the process of fertilization, and implantation. So when you go through this training, I'm sure you know this, but now it really relates to family planning and how the anatomy and the physiology of the female and male reproductive health relates to family planning. So this really helps us to understand that. And in Unit 4, it talks about counseling for family planning. We all will appreciate that for a woman to take on family planning, there is need for her to get good counseling from the provider. And without good family, because there is a lot of myths and misconceptions around family planning. So for a woman to take a step to actually accept family planning method so that she can space her babies, there is need for counseling. So the unit covers general principles of counseling for contraceptive methods and HIV prevention. It provides insights on knowledge and competency in counseling skills necessary while offering contraceptive methods. It also teaches us about balanced counseling strategy plus balanced counseling strategy plus as a counseling method. It's very informative on screening for reproductive coercion and intimate partner violence in relation to family planning services. It also clearly spells out myths and misconceptions on family planning so that when a woman comes with various myths and misconceptions, the counselor can be able to offer counseling along those myths and misconceptions and dispel those myths and misconceptions on family planning so that at the end of the day, the woman can actually take up the family planning method of her choice. Yeah. Then in Unit 5, it talks about the medical eligibility criteria. This has commonly been referred to as the MEC. So it covers details on the MEC. It provides a quick and visual reference to determine which contraceptive methods are safe for a woman to use based on her individual medical conditions and characteristics, ensuring that she receives the most appropriate and safe contraceptive option based on her health status. The unit provides insights on the purpose of the medical eligibility criteria, applicability of the World Health Organization medical eligibility criteria in Kenya, and the medical eligibility criteria for fertility awareness-based methods and for family planning contraception. The next will just show you how this MEC looks like. You can see the medical eligibility criteria. It is a kind of wheel. It's a wheel that will actually be able to show you if a woman has a particular condition, then this is the family planning contraceptive that she can actually take. Or if she has a condition that does not have, and some conditions may not allow her to take on a certain family planning contraceptive, and therefore you should be able to direct you which family planning contraceptive is then safe for that woman. So we have the MEC wheel within the training package, and you can be able to understand how you can actually use it to be able to determine what kind of family planning method is good for a particular woman, depending on her characteristic and medical condition. Yes. Unit 6. In Unit 6, it talks about infection prevention and control. So this covers details on knowledge, skills, and competencies on the basic principles of infection prevention and control, and recommended processes and practices. We realize that if service providers do not observe infection prevention and control, then the woman who comes in for family planning contraceptives would be in danger of contracting any other infections within the pharmacy. And this is something that is taken care of in Unit 6. So it provides insights on the standard precautions for infection prevention and control. It talks about the importance of infection prevention and control so that you can really appreciate that infection prevention and control within even your pharmacy is important so that women do not come out with infections that they did not come into the facility with. It talks about hand hygiene, personal protective equipment, and safe waste disposal. So Unit 6 takes care of that. In Unit 7, we now go into the specific family planning methods. And it covers details on available contraceptive methods in Kenya. And it narrows down to short-acting methods that pharmacists and pharmaceutical technologies may be able to provide. The unit provides insights on description of the contraceptive method, competency, and clinical experience needed in provision of the short-acting methods. Because as we've said, currently pharmacists and pharmaceutical technologists do not offer long-acting and reversible contraceptives, but they offer short-acting methods. So in this unit, you're able to understand the short-term acting methods and how actually to provide them to the women who come to you for these services. Yeah. And in the next, we shall be looking at the various family planning methods. You can see we have short-acting methods, long-acting and reversible contraceptive methods, voluntary surgical contraceptives, and natural family planning methods. We have under short-acting methods, we have the hormonal and barrier methods. This is the COCs, POPs, and the DMPA, intravesicular and SC DMPA. Then we have male condoms and female condoms. The long-acting methods, we have the hormonal and non-hormonal methods. And we have the copper-based IUCD. Then for voluntary surgical contraceptives, we have again male and female. We have the bilateral tubal ligation, BTL, and vasectomy. And for the natural family planning methods, we have the family awareness methods. Then we have BBT and the calendar-based methods. So I believe that within the pharmacies, you can offer both the natural family planning methods, because this is something that you can actually advise the woman on how she can be aware of her dates, her calendar dates, when she can be the safe days and all that, and the short-acting methods, which includes the pills and the injectables and the condoms for female and male. These others, the long-acting and reversible contraceptives and the voluntary surgical contraceptives, for now, pharmacists and pharmaceutical technologies, per the policy, are not allowed to offer them. Yes, let's go on. Then Unit 8 talks about integration and referrals. This covers details on services that can be offered within the community pharmacy and those which will require referral. The unit provides insights on integration of services that can be integrated within the scope of the practice of the pharmacy, services that can be referred maybe to the public health facilities, and an overview of HIV self-testing in Kenya. So that is Unit 8. Then for integration of services, for family planning and counseling and referral, description, we can cancel on all family planning methods. You can cancel and refer for long-acting and referral contraceptives. You can cancel and refer for family planning permanent methods. You can dispel myths and misconceptions about family planning. For provision of family planning methods, you can provide short-term methods, which includes DMPA, that's the injectables. We can combine oral contraceptives, progestin-only contraceptives. You can offer emergency contraceptives, female and male condoms. Those you can provide. In the area of STIs, including HIV prevention services, you can offer condoms and pre-exposure prophylaxis. HIV self-testing services, you can offer HIV testing services, pre- and post-test counseling, dispensing of HIV self-testing kits, and you can also refer them for other services for HIV. Then in post-rape care, you can offer information and optional HIV self-testing, post-exposure prophylaxis, emergency contraception, and referrals. You can refer in case there is services that you need to refer them to the public health facilities after rape. You can be able to refer those also. Then it also talks about HIV self-testing. And the goals for HIV self-testing is to increase uptake among population not currently reached by existing channels, and to increase testing frequency among populations with high ongoing risk of HIV infection. You can link them to treatment. The direct action you can do is link them to treatment. And this will, the impact is health for people living with HIV/AIDS. There is reduced morbidity and mortality. Then another action you can take is link them to prevention, which will reduce HIV transmission, and there'll be averted infections for HIV. So these are also services that because remember, we are talking about family planning integrated services. So you are not only talking, the guideline does not only talk about family planning, but it also talks about HIV self-testing, and what you can do within your pharmacies when people come to you for those services. Yes, let's keep going. In Unit 9, it talks about commodity, reporting, monitoring, and evaluation. Unit 9 covers details on the data tools used in the program, service delivery tools, and commodity management data tools. The unit provides insights on dimensions of data quality for family planning, documentation for family planning services, reporting processes for family planning, data flow for family planning, roles of pharmacists and pharmaceutical technologists in family planning data management, process of monitoring and evaluation in family planning and HIV self-testing, and FP indicators. So Unit 9 covers all that so that you can be able to document family planning services and report family planning services. If this is not done, then we really miss out on what the pharmacies and pharmaceutical technologists, we are not able to capture their data, so we do not know whether they are actually offering family planning within their outlets. And the dimensions that I covered for data quality is accuracy. I'll not read everything, but there is accuracy, reliability, completeness. Let's keep going. Precision, and this is that the data has sufficient detail to use for decision making. It also talks about timeliness. Data is up to date, current and available and on time. Integrity, the data is protected from deliberate bias, manipulation for political reasons or otherwise. Then in Unit 10, it talks about reproductive health commodity management. It covers details on family planning, health commodities, and their management. This unit provides insights on reproductive and family planning commodities, categories of family planning commodities, and logistics management for family planning commodities. Then the last unit is Unit 11. Yeah. Unit 11 talks of pharmacovigilance, and this covers details on pharmacovigilance, identification, and reporting on adverse drug reactions. The unit provides insights on the importance of pharmacovigilance, adverse drug reactions, and identification of their sources, roles and responsibilities of pharmacists and pharmaceutical technologists in pharmacovigilance, and guidelines and reporting tools for the national pharmacovigilance in Kenya. So those are the 11 units that this particular package talks about. And I would encourage everybody to actually attend this training so that they are completely aware of all what the policy is about pharmacists offering family planning within their outlets, and they are able to learn how to provide these services, how to cancel, and everything that I've talked about in the 11 units. So thank you very much. And that is what the additional resources are the National Family Planning Guidelines for Service Providers, HIV self-testing, and HIV self-testing and partner notification. So those are additional resources that would also add to this. So I would like to acknowledge the Ministry of Health, IRADCA, KPA, PSK, in supply, and partners who contributed to the development of this training package. It's a very comprehensive package, and by the end of the training, you should be able to really offer quality family planning within your outlets. Thank you. Over to you,
All right.
Hezron.
Thank you so much, Jane, for that insightful presentation. So I think we'll probably now move to Dr. Michael Mungoma, and then Dr. Isaac. There's a presentation we wanted to do with regards to the study that is coming up. So I'll just open the floor to Dr. Michael Mungoma, who's the chair for the Education Committee for the Pharmaceutical Society of Kenya, to just briefly talk about some of the trainings that have been happening, because I've been seeing some of the questions coming up on how you can be trained. So Dr. Mungoma will address that. Dr. Karibu.
Thank you, and good evening, everyone, and welcome to this sharing platform for the Pharmaceutical Society of Kenya, which continues to support continuous professional development through medical education and other means. As was mentioned there, my name is Dr. Michael Mungoma. I'm the chair of the Education Committee. And I just wanted to provide a short presentation. And thank you, Jen Otai. I think you've covered quite a bit of also what I wanted to share, which means that we were aligned even though we actually hadn't talked, which is positive. So for me, I just want to talk about the trainings we have had between January and March this year. And we've had quite a bit of members of PSK, pharmacists, joining into the training in various towns or counties in the country. A bit of repetition again of what I said, PSK having the mandate to facilitate CPD and family planning services beyond traditional dispensing is a focus. The MOH, of course, has supported through the approved curriculum. And we also have industry partners who are supporting the society and members who are eligible to be trained to provide these services. So remember, again, we are thinking beyond methods, we are thinking services, so that once you're trained, you're a service provider and not just a vendor or someone who keeps some of these commodities in your facility. I just want to take you back a little bit to what FIP talks about good pharmacy practice. I'm also aware that the Pharmacy and Poisons Board is working on this one. Practice of pharmacy that responds to the needs of the people who use the pharmacy's services to provide optimal evidence-based care. And to support this practice, it is essential that there established national framework for quality standards and guidelines. So the word quality again comes in, and that guided the whole process of coming up with this training package. So again, the FIP WHO guidelines, the joint FIP WHO guidelines on good pharmacy practice highlights one thing there that I picked up that is relevant to the context of our evening. A workforce framework that ensures competence of pharmacy staff through continuing professional development or continuing education programs like the one that we have for the family planning, defines the personnel resources needed to provide good pharmacy practice. So I won't stress again on this one. The training is a 5-day face-to-face. We are hoping that through some works that are ongoing, we'll bring in technology to harness the efficiency of this training so that we can get more and more people. We appreciate the fact that a lot of pharmacies have to make sacrifices and stay away from their workstations, those in private practice, keeping in mind that staying away for 5 days can actually influence profits, influence operations where you work, and so on. But again, it's one of those things that are clearly sacrifices that can build on to what you already have and create more opportunities in future in terms of eligibility to provide other services beyond family planning. By that, what I mean is that if you're able to acquire skills, including injecting, then you're a step ahead when it comes to other services that are going to be onboarded, because we're already thinking about immunization, vaccination. So it gives you an edge if you're able to have some of those skills already. So far, 53 pharmacies have been trained across 12 counties between January and March, courtesy of Philips and in supply. And those are the counties that are there. The impact and future outlook. Some of the immediate outcomes, the trained pharmacies are now offering effective family planning counseling, a skill that is sometimes lacking. Counseling is something that you really need to be trained and fully understand. It's very different as compared to advising. I know we had a session or maybe 2 sessions past COVID period. But again, we're saying here, it's always good to get the right skills so that you're able to provide effective services and the right methods, or refer appropriately. The training also has a strong component of referral. It's not just administration. So again, the other immediate outcome is strengthened integration of private sector pharmacies into the national FP program. We have family planning national goals that all of us need to be plugged in so that we fully understand how we can support the achievement of these goals. Then improved data reporting to the MOH platforms. The future plans include scaling up training to additional counties. So we just need to look out for PSK communications in the various platforms and ensure that we meet some of those eligibility criteria. And again, importantly here, if you sign up, please demonstrate some good level of commitment, because with these trainings, there's quite a bit of investment by some of the people that support us, so that even for our own planning as a society, we are able to count on you to come and complete the training. Enhancing pharmacists' participation in national family planning initiatives, like the one we've just had here of dissemination, and acquiring knowledge around family planning. Establishing mentorship, continuous quality improvement mechanisms, including reporting. Pharmacovigilance is also one very important component when it comes to this training, and that we're able actually to monitor side effects, adverse effects, know the differences, know when to report, because with a clear understanding of side effects and adverse drug reactions, then we are able to use some of the platforms at PPB more appropriately, so that again, we're not shy to really interrogate some of the situations that we have at our practice. So this is just some of the pictures that we have. Again, here to note that when we started this family planning training, we have now evolved, and we have produced train of trainers. Some of them are in the pictorials that we have, which means that we have also built capacity within the society for sustainability of this program. I think that is what I wanted to share. Just briefly, those are some of the references for the work, and a small quote here for you just to think about as we get on to the weekend. Thank you. Back to you, Hezron.
All right. Thank you so much, Dr. Mungoma, for that presentation and highlights of some of the activities that have been happening. So I think at this point, I'd like to welcome Dr. Isaac, and then thereafter we can have a Q&A session. Dr. Isaac, karibu. And meanwhile, as we wait for Dr. Isaac, I'd like to just remind you all that you don't have to send your email address on the chat. Your attendance is already recorded, so you don't have to send your email on the chat. And for those who are joining us on YouTube, we'll be sharing an image at the end of the session, which has the QR code where you can sign your attendance. And also provided will be a link where you can also just submit your details so that you can get your CPD points when they'll be sent by the CPD coordinator. I don't know if Dr. Isaac, you can hear me? But, meanwhile, I think I can welcome Dr. Joe to just give some few introductions of some of the team members who've joined us. Dr. Joe.
Thank you, Dr. Hezron. Just wanted to introduce Dr. Raymond Mutisia, just to say something since we have Uradka with us today. It is only fair that the member says something. Dr. Raymond, if you can hear me, salimia
Yes,
members.
yes, Dr. Joy. I can hear you clearly, and I hope you can hear me. Yes, this is a very important opportunity for Euradica to be able to disseminate policies, and there is a plan which we want to continue to ensure that at least all the policies which are relevant to family planning, we do disseminate them, because as my colleague has indicated in previous presentations, that policies are there, but many practitioners do not know about them. And I think it is important that we disseminate policies and ensure that at least providers on the ground do have an understanding what is available and what is their role. And of course, get to know how they can be able to make use of those guidelines and policies. I can see some of the questions they're asking about where they can get these materials or when they can be trained. That's a good indication that there is a need for you to be trained. And I think this can only happen if you're aware that such trainings are available, or if you're aware about the current policies and guidelines. Yeah, so with those few remarks, I think we can open the opportunity for the questions and see whether we can handle them accordingly. Back to you, Dr. Joy.
Thank you. Just before questions, I mean, I had Dr. Ezra say about Dr. Malonza having a presentation. Dr. Malonza, are you there?
Actually, Dr. Malonza was not having any presentation today.
Okay.
Yeah, so
No,
I don't know.
he was going to just talk about the GPP study, just to inform the pharmacists, since we have 1,000 of them. We thought it would be a good opportunity just to talk about the GPP study, so that we can have the pharmacists, maybe some of their pharmacies, since they're from all the 47 counties, maybe some of them will be approached by the research assistants. So we thought this was an opportunity just to talk about the GPP study that is starting next week on Monday.
Very well, very well. Dr. Malonza, are you online?
I am online. Yeah, I was not aware I needed to speak, but now that Jen has mentioned the GPP study, I'm happy to talk about it briefly. Can you hear me? Confirm you can hear me, Joe?
Yes.
That is a 5x5, very loud and clear.
Okay, thank you. So, Uradica is partnering with the Pharmacy and Poison Board as well as In Supply Health to run a national survey on what we are calling the Good Pharmacy Practice, GPP. Good Pharmacy Practice is a standard that the PPB has developed on various aspects of the pharmacy practice. But before they roll out this standard nationally, it was felt prudent that we should assess the current practice of pharmacy, both for pharmacists as well as pharmaceutical technologies, And also the facilities which we are managing out there, either pharmacies within hospitals or retail pharmacies in the communities, to see how they are performing based on this draft GPP standard. So we have developed a questionnaire based on the GPP. The questionnaire will be quantitative, where we'll be able to interview pharmacists from level 2 up to level 6. And we also have qualitative interviews. This is focus group discussions and key informant interviews for selected pharmacists as well as leaders in the health sector, so that we can understand the situation in which pharmacy practice is being implemented in Kenya. The idea is that we will learn from this assessment, and we'll also get ideas about how to improve on the GPP, and more importantly, support pharmacy practitioners in their work. And also, more importantly, for the Pharmacy and Poison Board to be able to improve on their role as the regulator for pharmacy practice in Kenya. So there is a committee that was formed by PPB to guide this process. It's called the Pharmacy Practice Technical Committee that Uradica and In Supply Health have been working with. And so over the last few months, we've been working on this. Some of the young pharmacists and pharm techs who have graduated over the last 2 years across almost 30 counties were identified through a recruitment process. And we trained them to be able to support us to do data collection in the field. So we are kind of ready. A number of counties have given us approval to be able to undertake the study. We already have national approval from Maseno University Ethics Committee, as well as NACOSTI. This is the National Commission for Science, Technology, and Innovations. But in addition, we usually require county approval. So we have more than 10 counties have already given us approval, and we are reaching out to other counties. So I think the idea was just to sensitize you that there is a good pharmacy practice assessment that is going on currently, and some of you may be engaged, may be involved, may be requested to be interviewed. So this was just to sensitize you to this process. And going forward, you will hear more about it. Once we do the study, we analyze the data, we plan to disseminate to you. So one of those disseminations, similar to what we have had today, may actually be a dissemination of the findings of the GPP study that we are going to undertake, so that all of us can be on the know, and we can also contribute to the results. And also we can help to improve the practice of pharmacy as we know it going forward. So I'll stop there, Joe, and if there are any questions on this study, I would be happy to take. But thank you very much for the opportunity, and back to Joe.
Thank you very much, Dr. Isaac Palonza. I know you're very passionate when it comes to research, so I wish you well. Remember, our members are very cooperative. As you can see, the number that has joined today, that shows you that sio CPD peke yake zinatafutwa. Members are ready and willing to be part of this. So I'll give it to Dr. Hezron to finish, so that now
All right.
Thank you very much.
All right. Thank you, Dr. John. Thank you, Dr. Isaac. So I think we'll just quickly move to the Q&A. Just look at the chat. I've sent a link to the PSK website, where you'll find all the information or documents about the family planning. So if you look at this website and you scroll below, you'll be able to find all the documents that you'll need with regards to family planning, the policies, some of the job aids, and reporting materials for PV and quality, all that. So kindly take some time, just visit our website and have a look at that. So we'll just dive right into the questions. And I'll start with the first question, which is regards to the use of DMPA IM, and the first one is from someone who's asking: a client receives DMPA IM, but after 2 weeks she tests positive for pregnancy and decides to terminate it. Is the injection still effective after the abortion, or does she need a new shot? So maybe as you respond to that, Jane, you could also respond to: is it possible to receive a menstrual period or not, ovulate after utilizing this method? So maybe you can respond to that as I look at some more questions.
I would give that question to Isaac or Raymond to respond to that.
Yes, let me take it up. This is Dr. Raymond. The question about whether a DMPSC can be effective after pregnancy while being on use or not is yes. You can actually use DMPSC injection even after getting pregnant or having an abortion, because it is still effective. Of course, it all depends on how it is used in terms of consistency and timelines. One has to follow the guidelines to be able to avoid pregnancy. If you don't follow the guidelines in terms of when you're supposed to be re-injected, then there's a high possibility that one may get pregnant. But of course, that does not mean that after getting pregnant, it will not be effective. So there are many other factors which may determine whether one may get pregnant or not. But of course, the main issue is that you can still use it and of course avoid pregnancy. The other question is about, is it possible to receive a menstrual period or not ovulate? Is it possible to receive a menstrual period or not ovulate? Of course, with DMPSC, there is amenorrhea, and of course, it is usually one of the side effects or one of the occurrence during the period you're using DMPSC. You cannot ovulate because ovulation is not usually is one of the ways which the method acts by stopping ovulation. So the question to that is that you may get amenorrhea, which is the commonest. You also may get menstruation at the same time. So it depends on the individual who is using that method. So those are the questions I've been asked to answer, Dr.
All right. Thank you. Thank you. Thank you so much. And I think the next question is from Professor Nyamu, who's asking: do you provide the materials for documenting the FP activities offered at the pharmacy level? So maybe one of you can respond to that.
Yes, maybe I can respond, but also Dr. Mugoma. Okay, Raymond, you can go forward, and Dr. Mugoma can also talk about it. Raymond, go ahead.
Yes, we do not provide materials as such. Our focus basically is on the research component and, of course, disseminating these policy documents.
Yeah, but I can also add that the Ministry of Health has IEC materials, some of which could be relevant for the pharmacy channel and would be made available for some of the programs going forward. So this is a program issue where there is support to the pharmacy channel. We are collaborating with In Supply Health, and for some of those pharmacies that are supported by In Supply Health, they are actually being supported with IEC materials, which have already been approved by the Ministry of Health, but also the PSK as well as PPB are welcome to assist your members to get some of these IEC materials. Some of them can also be provided electronically, and you can use them with your clients and others you may need to print. The printing is usually what is expensive offer. But I would like Dr. Mugoma to comment if he's still on the call.
Yeah, I think I support what you're saying. One, it's important to understand that it's not the Ministry of Health really providing some of these materials for the private sector pharmacists, but these things can be downloaded. I think as professionals, we should be able to access or even search suitable databases and get materials that are relevant or suitable for our premises. And as long as it is aligned to the MOH goals, we should be okay. Thank you.
All right. Thank you, Dr. Mungoma, for that response, and Dr. Isaac and Raymond as well. So there's another question with regards to the upcoming training. Maybe Dr. Mungoma, you can also speak on that as well. If there are any upcoming trainings.
So like I mentioned, trainings, these are going to be posted in our channels, that is the PSK WhatsApp groups. So currently there's nothing posted, meaning there's nothing upcoming. Thank you.
All right, thank you. There's a question on what are the shortcomings encountered on FP administration in a pharmacy, and what solutions are there to prevent the problem from escalating?
Yeah, maybe just to respond, I think shortcomings will be subjective. I think this is something that varies from premise to premise, business to business. Of course, the ones that we've had being reported sometimes is stockouts of various commodities like the DMPA, SC, but I'm informed that it's back in the market. I think beyond that, we are all expected, once we have been trained, to be able to create an environment where quality service can be provided, because I think that is the one thing that when we talk about an area where counseling can be done effectively, client confidentiality, privacy, and so on, that can be a challenge as well as an opportunity. Yeah.
All right, thank you. And I think there's a question from someone who's joined from YouTube, who's asking, where can these implants be sourced from?
Yeah, maybe I can respond.
Okay, all right.
Maybe
Thanks.
I can respond. Yeah, so currently, the pharmacy channel is not authorized to provide implants, but they can dispense implants. So the source can be twofold. You can get the implant from the wholesalers who usually supply you with family planning commodities, but you can also get them from the public sector if you already have a facility number. We call it the SDP number. If you are already linked with the public sector, you can be able to get implants from the public sector, but not for sale. But going forward, we are collaborating with the Ministry of Health and PPB and the associations to be able to do a feasibility and acceptability study and to determine whether implants can be safely provided within the pharmacy channel. Once that study is done and the results are positive, then we'll be able to work with the Ministry of Health and PPB to develop a policy to allow pharmacists and pharmtechs to actually provide implants in their facilities. So currently they can only dispense, but getting the commodities then has to be from your wholesalers or from the public sector. Thank you, and over.
Right. Thank you, Dr. Isaac, for that response. And I think we'll just take the final question from a member who's asking why there's no section on pharmacology and pharmacokinetics of hormonal contraceptives mentioned in the guidelines or the training materials. I know who can
I
assist.
think this is not the training that is offered on the injectables is not a pharmacology training. So so we don't go into details about the pharmacology of the drug of the product. It is more about the mechanism of action and also the side effect that may arise due to the use of it. So that's how the curriculum is focused. But when it comes to the pharmacology of the molecules that are involved, I think that is outside the realm of the curriculum.
All right. Thank you so much, Dr. Isaac, for giving that response. So I think I'll just open the floor for parting shots. And I think we'll start with Jane, and then we can have Dr. Mungoma, then Dr. Isaac, then Dr.
Thank
Joe.
you so much for turning up for the training. I think with the numbers, people are very interested and looking at the questions. With more training, more pharmacists would be able to offer injectables within their pharmacies. So I would really encourage as many pharmacists as possible to undergo the training so that one, it increases their knowledge. I also am aware they're in business, it increases their business, but it also allows more women to have access to family planning contraceptives wherever they are, because we know that pharmacies are well spread within the country. And when they have knowledge and are able to offer quality family planning services, then we shall have more women accessing family planning, and we shall be able to reach our goal by 2030 of 66% of women having access to family planning. So I would encourage everybody to actually take on this training. Thank you. And thank you for turning up for the training, for the webinar.
All right. Thank you so much, Jane. And meanwhile, as we have Dr. Mungoma giving his parting shot, I'd like to remind those who have joined us on YouTube. And please note, this is only for those who've joined us on YouTube. You can mark your attendance here using the QR code, or you can use the link that has been provided on the side, bit.ly. You can just scan it and get your attendance marked. And for those who've joined the webinar via Zoom, you don't have to scan because your attendance has already been recorded when you joined the meeting. So Dr. Mungoma, kindly give us your parting shots. Dr. Mungoma? I can see you're unmuted, but we can't hear you. Maybe you can try reconnecting again. I think there could be a problem with the microphone. Maybe you can go Dr. Isaac first.
Thank you, Hezron. I would really like to thank PSK for organizing such a wonderful and impactful webinar, and also for getting the information out there to all your members. We already had over 1,000 participants on this webinar. Congratulations to PSK. And more importantly, I would like to recognize Hezron and Kamau for organizing this webinar and for working very closely with Euradika I would like to recognize my colleagues, Jen Otai, who made the presentation, and Dr. Raymond Mutisia for participating. So we are very excited about our collaboration with PSK and working together. I know that sometimes those of us who are in the retail pharmacy, we focus on profits. We have to make some money in order to make our facilities sustainable. But I think for family planning, we are doing more than just doing business. It's an opportunity for us to improve the health and the well-being of Kenyans. And that's what Euradica stands for. So we really want to thank all of you and to thank you as a society for collaborating with us and to helping us to achieve our mission, which is improving the health of Kenyans. So thank you so much for that opportunity. Over.
Right. Thank you so much, Dr. Isaac. Dr. Mungoma, I don't know if you're able to unmute now. I think there seems to be a problem because there's no sound coming from your side. Meanwhile, for those asking about scanning, you don't have to scan. This is only for those who have joined us via YouTube. If you're in this meeting on Zoom, your attendance is already recorded. Maybe we can have Dr. Raymond, you can maybe say something and then we finish with Dr. Joe before the announcements.
Yeah, mine is just to thank everyone for making this event a success. This webinar was quite successful. Looking at the attendance as it has been indicated. And also want to assure you that Euradica will be continuing providing these webinars if opportunity arises. And as Isaac has said, that immediately we finish with the study, we'll be able to disseminate that information. And of course, it's also a good opportunity for us to be disseminating any other study we do as Euradica, which may be relevant for pharmacy and for your information. Thanks a lot. Back to you.
All right, Dr. Joe.
Thank you, Dr. Ezra. My members is to thank you for coming in. Every question asked here is very important. I don't wish to. The issue of pharmacology, as you know, mechanism of action is also pharmacology by itself. So we are yet to see more because the program is also growing. We will always update you on anything that is coming up, and once we get even insights from you, we are happy. I see as we close, I see a very important question here. I don't know whether you answered it about Jadel and implant causing infertility by someone called Kevin Mwangi. I think it's just the delay of the hypothalamal and pituitary axis, such that there is delay in fertility, but people do not really get infertile all their life. So it's just a delay in the hypothalamal pituitary axis, and I think most of us have come across this in several clients. So I think mine is to say thank you very much for attending, and I have an announcement, by the way, just a quick one. We had a webinar a week or 2 weeks ago about exploring abroad, pharmacists exploring abroad. We are thinking of bringing back session 2, just like the way we brought the dissemination of policies, FP policies. So I'd like us to stay tuned, social channels and WhatsApp. We shall be giving us our members the date so that they can join us. So with those few remarks, nawatakia alamsiki na usingizi mwanana. Asante sana.
All right. Thank you, Dr. Joe. And just another reminder before we close, ensure you subscribe to the event on the PPB portal. Remember, the sooner you subscribe, the sooner the CPD coordinator will be able to send you your CPD points. So if you've not subscribed for the last 2 weeks, for the webinars we've had the last 2 weeks. Kindly ensure that you do so that you can get your CPD points. Otherwise, the CPD coordinator will be forced to wait until he has enough tokens so that you can all get your CPDs. As we close, for those who have any challenges with scanning the QR code, kindly reach out to PSK communications at psk.or.ke, and then we can assist you on that. And remember, this is specifically for those who joined via YouTube, not for those who joined via Zoom. This coming Tuesday next week on 25th of March, we'll be having a conference trivia night webinar. This is where you'll get to learn more about the conference. And please note that there will be some prizes for grabs during the session. So ensure that you join so that you get some awards. You might get probably a coupon for the conference. So just ensure that you join the session. Next week as well, on 27th March, we have a webinar that will be happening in partnership with Helion. And this time round, Professor Ermias will be tackling low back pain solutions with targeted treatment options. Remember, if you have any challenge signing up on the Helion platform, we are ready to assist you to register and be able to join the meeting. So kindly reach out to us on our WhatsApp or our email, and we'll be able to assist you on that. A reminder, the early bird discount for the conference is about to end. This will be ending on 31st of March. So if you are registering for the conference, ensure that you take advantage of this early bird by 31st of March. The call for abstracts is still ongoing. So if you would like to present an abstract during the conference, ensure that you submit your abstract before 15th of April. And finally, these are just the rates for the conference. You can also visit our portal, our members portal, and you'll be able to access this information so that you can do your registration. And finally, always a reminder, if you have your patient experiencing any adverse events or poor quality health products, you can report that by 3 options. The first 2 options are for the healthcare professionals. You can use the pv.pharmacyboardkenya.org website, or you can use the mobile application, which you can download from the Apple Store or the Google Play Store. And finally, for the members of the public, they can use the USSD code *271#. Once again, thank you for joining. And thank you to all our speakers, Jen, Dr. Malonza, Dr. Raymond, Dr. Joe, Dr. Mungoma, asanteni sana for the presentation. And to all members, thank you for joining us tonight. For those on YouTube, I'm going to leave this running for 5 minutes before we close so that you can mark your attendance. Remember, this is just for those who are on YouTube and not for those who joined us on Zoom. Thank you and have a good night.